Hi, this is a lecture about DSM-5 or Diagnosis and Statistical Manual of Mental Health Disorder, 5th edition. My name is Alvin Molina, and I am a registered nurse and a graduate from University of Santo Tomas, and currently a student of Master of Science in Health Informatics in the University of the Philippines, Manila. As I go through my slides, the following objectives of this lecture must be achieved. First is to define what DSM-5 means. Second is to discuss the history and creation of DSM. Next is to know the difference between DSM-4 and DSM-5, and also to know the purpose of DSM in medicine, specifically in psychiatry, and also to know applicability of DSM in practice. And lastly is to identify new codes of DSM-5. But let us know first what Diagnostic and Statistical Manual of Mental Health Disorder is. The Diagnostic and Statistical Manual of Mental Disorder, DSM, is published by the American Psychiatric Association, or APA, and it offers a common language and a standard criteria for the classification of mental disorders. It is used or relied upon by clinicians, researchers, psychiatric drug regulation agencies, health insurance companies, pharmaceutical companies, and the legal system and policymakers, together with alternatives such as ICD-10, Classification of Mental Health and Behavior Disorders, which is produced by the World Health Organization. DSM is now in its 5th edition, or DSM-5, which was just published on May 18, 2013. The DSM evolved from systems for collecting census and psychiatric hospital statistics and from a United States Army manual. Revisions since its first publication in 1952 have incrementally added to the total numbers of mental disorders, although also removing those no longer considered to be mental disorders. And for us to understand more DSM, let's deep dive more on its. DSM was first developed during the pre-World War II because they felt the need to collect statistical information. It was in 1952 when they saw the large-scale involvement of U.S. psychiatrists in the selection, processing, assessment, and treatment of soldiers. This moved the focus away from the mental institutions and traditional clinical perspectives. And during the post-World War II, they have identified to have a better incorporate the outpatient presentation of World War II servicemen and veterans. It was during the 1960s there were many challenges to the concept of mental illness itself. These challenges came from psychiatrists like Thomas Szasz, who argued the mental illness was a myth used to disguise moral conflicts, from sociologists such as Irving Goffman, who said that mental illness was merely another example of how society labels and controls nonconformists. Until 1974, the decision to create a new revision of DSM was made, and Robert Spitzer was selected as the chairman of the task force. This was the development of DSM-3. The initial impetus was to make DSM nomenclature consistent with the International Statistical Classification of Diseases and Related Health Problems, or ICD, which was published by the World Health Organization. In 1987, DSM-R, or RAND, was developed and was published as a revision of the DSM-3 under the direction of Spitzer. Categories were renamed and reorganized, and significant changes in criteria were made. 6 categories were deleted while others were added. Controversial diagnoses such as premenstrual dysphoric disorder and masochist personality disorder were considered and discarded. And in 1994, DSM-4 was published, listing 297 disorders in 886 pages. The task force was chaired by Alan Francis. A steering committee of 27 people was introduced, including 4 psychologists. The steering committee created 13 work groups of 5 to 16 members. Each work group had about 20 advisors. A major change from previous versions was the inclusion of clinical significance criterion to almost half of all the categories, which required that symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Some personality disorder diagnoses were deleted or moved to the appendix. And in 2013, DSM-5 was developed. The 5th edition of Diagnostic and Statistical Manual of Mental Disorder, DSM, was approved by the Board of Trustees of the APA on December 1, 2012. It was published on May 18, 2013. which contains extensive revised diagnosis and in some cases broadens diagnostic definitions while narrowing definitions in others. A significant change in the 5th edition is the deletion of subtypes of schizophrenia, which is paranoid, disorganized, catatonic, undifferentiated, and residual. But why is DSM important? This manual is important to you because the DSM is the most widely used mental disorder manual in the United States, and it is actually utilized by a diverse group of mental health professionals. DSM is used to determine and help communicate a patient diagnosis after an evaluation, and it is a requirement of hospitals, clinics, and insurance companies to use DSM classification. And with its very recent changes, it is very important as well to know the difference between DSM-4 and DSM-5. There are actually 7 biggest changes from DSM-4 to DSM-5. First is the modification of artificial categorization. DSM-4 used to have a multi-axial approach, while DSM-5 is now a simplified and non-axial documentation. The DSM-4 used an axial system to group disorders into 5 broad categories or groups. First is the clinical syndromes or disorder, personality disorder or mental retardation. Third is medical condition. Fourth is psychosocial and environmental stressor. Fifth is global assessment of functioning. With DSM-5, they have combined the first 3 axial into one, which is the mental, psychiatric, personality, and medical condition. And they have the psychosocial and environmental factors, and the third is disability or global assessment of functioning. Other significant changes was with the autism spectrum, because in DSM-5, 4 separately classified issues that are unfortunately very common have been unified under the header of autism spectrum disorder. The previous categories of autism, Asperger's childhood disintegrative disorder and pervasive developmental disorder, are no longer in use. Others are elimination of childhood bipolar disorder, revision of ADHD diagnosis, increasing detail on PTSD symptoms, reclassification of dementia, and lastly is the intellectual disability, which is included in the 3rd simplified axial documentation. There are a few new diagnoses as well in the development of DSM-5. First is the disruptive mood dysregulation disorder, which is a disorder of childhood manifested by frequent, spontaneous, inappropriate outbursts of uncontrolled rage, superimposed on persistent irritable moods. Hoarding disorder is a compulsive accumulation of unnecessary articles or even animals can create unsafe situations. Binge eating disorder is an eating disorder characterized by rapid, uncontrolled eating of so much food as to lead to physical discomfort even when not particularly hungry. Bingers may eat alone to avoid embarrassment, but bingers may be followed by feeling of guilt, disgust, and self-loathing. And excoriation disorder or skin picking. Skin picking may result in significant tissue damage and often leads to medical complications such as local infections and septicemia. Skin picking disorder affects around 2 to 5% of people in the United States. Here are just some few of the revised diagnoses and DSM-5 as well. We have autism spectrum disorder, post-traumatic stress disorder, pedophilic disorder, substance use disorder, specific learning disorder, and removal of bereavement exclusion. Here are a few of DSM diagnoses in the new ICD-10-CM codes as ordered in the DSM-5 classification. You can see here in my example are the disorders that are included in DSM-5 or in this DSM-4 in their codes in ICD. Take for an example obsessive-compulsive disorder and hoarding disorder. They used to share the same code of F42, and with the new code for the use of beginning in October 1 of 2016, they have different codes of F42.2 and F42.3. Here are just some other codes for some disorders, like with PICA, avoidant restrictive food intake disorder, and binge eating disorder. And that ends my discussion. Thank you so much.